So yeah, thank you for inviting me to talk, and been very interested to listen to those previous speakers. There will be some overlap with what's been said before, but I just want to put, I suppose, a slightly personal take and personal spin on all of that fantastically interesting information we've heard from both psychology teams, academics, and also, of course, from the patient and charitable view from Helen. So this is my take on it. I'm a neuro-oncology surgeon. That is now all that I do from a neurosurgical perspective. So I've got a particular passion and interest in this area. So I thought I'd start by explaining what shared decision making means to me and how I've used that in my clinical practice. And some of this you've heard previously, but the one important part about this for me is this one sentence at the top of the screen. And that is, this for me is about having an honest conversation about reasonable competing options with our patients. And there's quite a lot of information in that one sentence. The first part, and I've highlighted that in bold, is about having an honest conversation, and others touched on that today. But for me, this is really, really important when we're dealing with some very difficult situations. Helen talked about that patient with a glioblastoma, for example, patients with cerebral metastases. I think it's really is incredibly difficult to have these conversations, and it's also quite easy not to be dishonest, but not to be quite as honest as you might want to be with your patients up front. So highlighted in red, and this talk is having a focus around the decision grids, and I'll come back to that in due course, but that's the conversation you have really needs to be supported by evidence-based information, preferably evidence-based from your own clinical practice as well as clinical studies and trials, and obviously focus on the benefits and risks of those treatments that we have available. It is, as we've heard already, a conversation, and that is that it's a two-way process. There are two people, or more than two people in that room. You as a clinician, the expert who's entered the room with that information about risks and benefits and treatment options, but the patient and their family, who are of course experts in themselves, in that patient. And we have to explore the patient views, preferences, values and beliefs. And one of the most challenging parts of shared decision making, I think, for clinicians who haven't practiced this much, is actually getting into the mind of their patients and working with them in the manner that Helen described to actually extract that vital information about what matters most to them. So this is a conversation, this is a two-way process. It's not simply presenting a series of options and leaving it to your patient, it's helping them through those choices. And to be perfectly honest, I know I'm talking about decision grids today, but the most important part about shared decision making to me is the quality of that conversation. There are, and we've heard already, a number of advantages to shared decision making, and this is my personal take on it. We've heard that people want to be more involved in making decisions about their care. Another important thing, and it goes back to that honesty piece, is that both patients and clinicians, and this has been shown in research, both patients and clinicians tend to overestimate, and quite often significantly overestimate, the benefits of treatments and tend to underestimate the risk. And of course, if you do that as a clinician with your patient, you might well have a patient making an uninformed and inappropriate decision. So we really do have to be really honest with patients to help them through this difficult time. There's a good evidence now that if we all work in this way together, that rather than our clinical biases that will direct patients to one treatment or another, that with patients making informed decisions in a shared decision-making way, that we will eliminate that unwarranted clinical variation that is well established. There's good evidence that patient satisfaction will improve, patient experience and knowledge will improve, and indeed outcomes and safety will improve too. If that's not enough for you, then another bonus, and this is a real challenge in many healthcare structures now, including in the UK, litigation is a huge problem. And shared decision making is now embedded into our GMC guidelines from November 2020 on consent. It's now in place in the NICE guidelines from June. So it's really no longer an option or a luxury. This is a mandatory process, and you will suffer the consequences of that by having dissatisfied patients who may litigate if you don't do this well and properly. So just briefly, I guess I was always someone, I spent years talking to patients with brain tumours, thought I did it very well. I then spent some time in 2016 getting trained in shared decision making, really an exploratory thing for me. I thought, well, actually, I can do what I've been doing hopefully quite well, even better. And this really was a new way of thinking and talking to patients for me, and it's been greatly beneficial to me and my patients, I hope. So we had some training, I had some training, we did some cascade training in-house, and this is a team sport. So this means all of the team, the registrars, the consultants, the clinical nurse specialists, everyone involved in the care of the patients gets training in this methodology. We also then develop these decision grids, and I'll talk a bit more about these decision grids now. But the common situations that I encounter in my clinic are obviously high-grade glioma, low-grade glioma, patients with cerebral metastases, and I put it in brackets because we added this into the second year of our work with shared decision-making, patients with meningioma. And I guess now we've developed decision grids around those 4 common themes, probably accounts for about 90% of my practice overall. It's not that you have to have a decision grid for every condition and every situation that you encounter. As mentioned before, it's more about the quality of the conversation and the way of thinking. But we now, having developed these decision grids, discuss up to 3 options, 3 reasonable options with our patients. This was already mentioned. Not only do we need a trained team, and I talked about that, but we need prepared patients too. So all of our patients now are sent this out either electronically or in a physical paper form. This is just to set them up to, we want to have this type of conversation with you. Please come along and ask us what my choices are, what's good and bad about each choice. How do I get support to make a decision that's right for me? You'll see at the bottom, this is all about shared decision making. And we want patients to tell us what is important to them. So prepare your team, prepare your patients. Design some decision grids. Now they are, as I've written in red at the bottom there, there's lots of different ways of doing this. There are grids, there are templates, there are infographics, there are interactive processes online. Have a look at if you Google search option grids, that will give you some good ideas. When we started doing this 5 years ago in neuro-oncology, there wasn't really anything that we could borrow. There are in a number of clinical scenarios now tools that have been developed and used by others that you can acquire and borrow and use for your practice. That wasn't the case in neuro-oncology, so we had to come up with something ourselves. So what we did was we chose quite a common template or an amalgamation of a common template, and that template's set about asking these sort of 5 questions, or the 5 questions that patients might need some answers to. In terms of the treatments, for whom does this work best? What will this involve? What are the advantages and the disadvantages and the risks? And essentially we present in these decision grids 3 common options, and 3 really of the 4 options that are mentioned here. The first option, and depending on the clinical scenario, is either an option of sort of conservative care that might be best supportive care in a patient with a high-grade glioma or cerebral metastatic disease. It might be active surveillance in someone with a low-grade glioma or a meningioma, for example, with radiological and clinical surveillance. Another option for patients with intrinsic tumours might simply to have a biopsy, followed by another shared decision-making conversation about chemoradiotherapy. For patients with meningiomas or metastases, it may be that there's an option for stereotactic radiosurgery. And finally, for some of these patients, there will be an option for a craniotomy to remove that tumour. And that's a very common set of conversations that we're having with our patients. I'm not an expert in this. You've heard experts talk about this today, but this was my simplistic take on how we came up with the grids that we designed. And the first message that I heard loud and clear from many experts was keep it simple. And I would say that the way that we use these tools is just to support the conversation, in that we've had a conversation, then we share this resource as a summary of that conversation with our patients, along with a clinical letter that sets out the discussion that we had. Make it easy to read. Don't forget that the average reading age in many populations is between 9 and 12 years of age, so make it in fairly straightforward language. Consider the use of infographics. We didn't use them, but there are some fantastic tools that use infographics. They're particularly useful, those infographics, when it comes to representing, we might commonly talk in percentages, but it's not a good idea to use percentages because many patients don't fully understand what a percentage means. So if you are to use numbers as we did, it's recommended that you use a proportion, a 1 out of 100 or 1 out of 10, whatever it might be, but not a percentage figure. Nicer still if you've got some pretty infographics showing, 100 blue dots and 1 little red one. Patients can really understand that very clearly. If you are to compare numbers, which we often do when we're balancing risks, better to use the same fraction. So 1 out of 100 patients compared with 5 out of 100, rather than saying 1 out of 100 versus 1 in 20, because some patients struggle to make sense of that and make a sensible comparison. Really useful to involve patients and other experts in the design of these grids and testing them out. And actually, Helen, who spoke earlier, was someone I turned to for advice on the design of the grids that we've used. And absolutely use evidence-based data, but better still, use your own clinical data. If I'm talking to a patient about awake craniotomy and I've done an audit of the last 500 cases, I've got really robust data in terms of having an informed decision with my patients. Now, I don't for a minute want to go through the details of this. There's much too much on this slide for you to take in, but this just highlights the kind of grids that we share with our patients. Those 5 questions that I referred to earlier: for whom does it work best, what does it involve, advantages, disadvantages, and risks on the left, and those 3 options across the top. And this is kind of a framework in how we have a conversation with our patients. And the way I have those conversations, I tend to start on the left-hand side on that best supportive care and natural history and work my way up to the more interventional options. But this is how we set it out. And the grid that we use for low-grade glioma obviously starts with the best medical care is more a surveillance option. We're looking at scans, and patients with metastases, we might put on that slide stereotactic radiosurgery versus craniotomy. Now, important to say that not all 3 of these options, of course, will apply to every patient. I still might present this conversation to them and this chart to them, but if I've got a patient where I think the tumour is inoperable, bilateral diffuse glioma, for example, where clearly there seems no logic or sense in carrying out a craniotomy, then I'll explain to my patient, we've considered this option, and for the following reasons, I don't believe that this is an appropriate option here, but we have thought it through, and I can use that to talk to the patient. And likewise, stereotactic radiosurgery, clearly not going to be appropriate for patients with larger tumours. So the options are there, they're there to discuss. I use this to support the decision. I hand it to people after we've had a conversation to try and summarise what we've discussed. Very briefly, when we introduced this, we did some tests of both staff and patient satisfaction, if you like, and there's a questionnaire we use for our staff to look at their attitudes and experiences of SDM, and in summary, there was a substantial improvement in every domain of this AQUA questionnaire amongst our staff using SDM. Questionnaires were referred to earlier. How do you ask patients to check in with them that you have had a shared decision-making conversation? Well, the tool that we originally used was this Collaborate 3-question, maximum score 27 on this questionnaire. We didn't find this particularly useful or particularly sensitive, and we've now switched to something called the SDM-Q9, where there's actually both a clinician and a patient aspect to that questionnaire. So other tools, as we heard earlier, are available to determine how quality your conversations are with your patients. What we did find, as you can see, is that the patients reported incredibly high levels of satisfaction, if you like, or engagement in those conversations using that Collaborate questionnaire. So just in terms of a little bit of a journey, for us, I guess we have been on a journey, and I won't discuss the details of these patients as I have done in previous talks for the purposes of time. But needless to say, I guess I started off my career where, due to the biases that were mentioned earlier on in this meeting, due to the biases in the way I presented this information to patients, more often than not, almost every patient chose to have an operation if that was offered to them, virtually every patient. And indeed, when I first had a patient who said, well, thanks very much, I heard you mention that option for not having an operation, Mr. Grundy, I'd rather like to not have an operation. I found that incredibly difficult to deal with because I was used to everyone saying, yes, please, I want an operation. And I've spent some time trying to coach the patient down and persuade him that he'd made a bad decision, but actually he'd made the absolutely right decision for him. I now reflect. 5 years later, when I started, 5 years ago now, when I started to do SDM, I'd had some training, I'd started to use this technique, but we hadn't trained the whole team, and we always have a nurse specialist sat in with us. Another similar story. This time a patient with a high-grade glioma chose not to have any treatment, a perfectly sensible decision, an excellent conversation, scored 27 on their Collaborate questionnaire, so felt very engaged with me. When he walked out the room, the CNS turned to me and said, "That guy's made a terrible decision. He must have an operation. We must go and talk to him again." 2 years ago now, whole team trained, everyone engaged with this way of thinking. My fellow's talking to a patient in a very difficult situation, a young patient with a glioblastoma, talked through some very challenging decision-making with them about how this tumour had affected their quality of life and had taken away their ability to do the things in life that they wanted to do, which for this patient was go to the gym and drive his fast car. Wasn't able to do those things again, never would have been able to, and rightly or wrongly for him, that meant that he did not want to pursue treatment. But at this stage, you've got a whole team of people now supporting that patient and his family. So we found SDM to be incredibly beneficial and rewarding. Patients will report very high levels of satisfaction when you use this technique. We have found that it takes a little longer to do this in our clinics, and of course it's a dynamic process. It's not just a conversation. The grids that we use, we share with our patients as we do with the clinical letters and information sheets, and suggest to them often to go away and have a think through what we've discussed, and check in with us later on that they feel that they have made the right decision for them. We're not sure, and one of the drivers for this has been an incentive, I suppose, from bodies like NHS England who fund healthcare in the UK. There is some evidence that patients are less likely to choose interventional options if you use shared decision making. Of course, those options cost an awful lot of money that could potentially be saved. We haven't studied that yet. We will go on and study that, but that wasn't our primary driver here. It is, as I mentioned earlier, a new standard of care. So for anyone thinking that they want to implement this into their own practice, there are some stages to work through. We've talked through some of them already. You need to prepare your patients and the public. I mentioned the Ask 3 questions. You need to have systems and processes in place, and those decision support tools and aids need to be developed for your common pathways. You need to train your teams, and then there's a final aspect related to commissioning. So just to finish off, this was a genuine and unsolicited piece of feedback that we received a few years ago now, about 3 years ago, from a sister of a patient who very unfortunately had a glioblastoma in his motor cortex, and we had to make quite a challenging decision about whether we did a risky operation or not. And my registrar spoke to the patient on the ward. He was then discharged home, came back and spoke to my fellow. I only met him on the day of surgery, so all the credit here goes to my team, who are all trained experts, I think, in shared decision making. And the point that I've written here in red, hopefully, was the important part for me, and that was the feedback that we put the patient so firmly at the centre of every single decision that we made and all that we do. And honestly, as I said there, that was so kind. That's the best feedback anyone could have given me in this context. So thank you very much.
Thank you very much, Paul. That was a really, really interesting presentation. So I would like to invite the other speakers and chairs to switch on their cameras again, and then we can begin answering some of the questions from the audience. I think the first question might be for Helle, but I'm not. Please feel free to chip in. It's Sarah Andrew is asking, in your study, was there any assessment of a patient's communication ability, i.e. any receptive or expressive dysphagia impacting on access to information and decision-making tools? I think that probably was a question for Helle, but I guess it's applicable for all of the speakers about communication issues and shared decision-making.
Yeah, but I would like to answer for in our question, we didn't do any assessment of our patients before including them in the study. Our inclusion criteria was that the patient should be able to have a conversation, meaning that they should be able to talk in sentences. So the patients that was only able to answer yes or no, they couldn't be included. But if they could communicate a whole sentence, then they could be included. if the research team had any questions about a patient's ability to be included in the study, we had the possibility to consult a neuropsychologist or our medical specialist for advice.
Thank you, Helle. Paul, I was wondering how would you deal with that in your clinical practice?
Yeah, I was just thinking that so the whole thing about shared decision making, whether it's a grid or the conversation, is it has to be tailored to the patient, doesn't it? And you know, there are issues with mental capacity in some of these patients. There are issues with speech. I would say there's almost always a way through that. There has to be, because we need informed consent if we're going to go ahead with an intervention, for example. So you do have to tailor your conversation. You do have to use the family sometimes to help. You do have to use what they can tell you about the patient too. In terms of the decision grids, I don't think what we've written are actually written in the most patient-friendly format. But as I say, I use that as a sort of supplement to the conversation that we've had. And I think the conversation's the important part of it. We do tailor it though, and another thing I suppose I didn't mention at the time, I put some risks in those. They're generic risks, but of course the risks of one operation for a high-grade glioma aren't the same as the risk of another operation. And we have a very easy way where we can modify that on the chart. But equally, not all patients understand risk percentages and proportions in the same way as one another. So you really have to, again, work that out with your patient as part of the conversation and try and explain things in a way that they can understand. With patients with severe dysphagia, that can be very, very difficult sometimes. I'm not going to hide away from that fact, but you just have to take your time and work through it with the support of the family quite often.
Question is there a best practice or used framework for the best way to discuss financial aspect within diseases care within the shared decision-making model? So discussions about financial.
Do you mean about personal finances or?
Yeah, I think so. I guess so.
Yeah. I guess it's fair to say from a neuro-oncology surgical position, that's not a conversation I enter into very much, but it is very much a conversation that sometimes the people who support us, like our specialist nurses and other members of the team, and I'm sure at conversations that Helen may also have with patients to support them through sometimes some really challenging times. So I don't know, Helen, do you have an observation on that?
Well, I know, you know, we have Macmillan in the UK, which offer finance and benefits. But there isn't, to answer that question specifically, I don't think there is a best practice or used framework. But again, I think if you come at it from a patient-centered approach where you're asking them what it is they're struggling with financially, and then that opens up the conversation so you can begin to signpost to where they might get help, you know, whether it's individual grant giving bodies locally or family rallying around. But there isn't a best practice framework, no. But we would always do it on a one-to-one. We have a finance clinic, benefit clinic.
So Paul, I was thinking, how did you train your staff? Could you come with some recommendation to us?
Some of us, myself included, went to a couple of training days by NHS England. So there's some central training days where a team of experts, we spent a day, I've been twice to those meetings, and they provided us with some resources as well, of course, as some knowledge to convey. And so a lot of what we did was then cascade training. So every time I have a new junior doctor who works with me, I'll sit down with him before we start working together and actually have a conversation. I have a presentation about shared decision making, how to hold those conversations. We've done it as a team. And then a lot of this is experiential, isn't it? You know, I've sat down and we've sat down with our nurse specialists, for example, now thousands of times having these conversations. And I guess it took a little bit of time for us to learn that this was a different way of talking to patients, as I hinted earlier. So yeah, a lot of that was cascade training. We've got the skills, we now pass them on. I actually run a project in this hospital now where we've done a training day for the whole hospital. So we have a process we're trying, and Helen's actually a representative for on our trust board at the moment for shared decision making. So we're now working with teams across the entire organisation where we're training individuals and teams. We're helping them design decision grids across every spectrum of clinical practice. and hoping that those teams in due course will cascade train other members of their team and so forth. So that's the way that we're still working.
Thank you, Paul.
Thank you. I see we have another question about sort of the how this works in clinical practice. It says, do you carry out the appointment in two parts to allow patient and family to have a time out to consider all the different factors before making their decision? So how, I guess how do you make this work in practice, really, because time is often so limited?
Yeah, and I think it's breaking up a little bit, the connection, but it takes longer to do this properly. So the first thing that we did quickly was realize we needed longer with our patients. And I know, like, I'm the chief medical officer here, and I know the management in the trust might be saying you can't have somebody to determine that I would give myself permission to have longer with my patients. So that is really important. What I would say is a lot of patients can make a decision with you in that time frame, but some of them can't. I quite often feel just given you an awful lot of information, we've discussed something very complex, you might want some more time to think about this over the next few days. And over those few days, I can provide you with some more information, a decision grid, a letter that I'll write to you in person, information sheet about treatment, and follow-up consultation or phone call. So we do offer them time. I would say probably the majority, if you've had a good conversation, actually will want to and be able to make a decision there and then, but we always offer them that option of either coming back again or having a follow-up and having some more time. And I think that's really important because I don't want patients to feel under pressure that they're sat there in the hot seat and have to make a decision here and now, because I think that would be wrong.
Paul, have you got to the place yet where you're beginning to look at decision or regret, or is it still too early?
No, so one of the what we're trying to do with the work we're doing on shared decision making at the moment, as you know, Helen, is we're trying to build in an electronic resource called My Medical Record to support the patients on their journey. My vision with this is that before the patients come and see us, we'll have shared this resource with them, and there'll be information on there, for example, that asks 3 questions. This is how we're going to talk to you, but also to get some information from them about what matters most to them before we've even met them and seen them in the clinic. Following on from there, we hope to be able to upload that resource when we have met them with information sheets, decision grids, but also we're doing some patient-related outcome measures, including a decision regret tool. And I think that will give us a huge amount of information going forward about the quality of conversations that we're having. And, you know, decision regret, Helen, you'll know that I've had some personal experiences, family experiences recently where I've seen firsthand that, you know, decisions that people have made close to me that have been perhaps not as well informed or shared as possible, and there has been a massive amount of decision regret. I think that is a really big issue. We are going to test it. We are going to ask patients questions about that. There's a bit of a fine balance here between overwhelming patients with so many different questionnaires, but decision regret, I think, is one of those useful things we are going to incorporate into that post-consultation feedback.
Thank you.
Thank you very much. I'm just going to share my screen here. So thank you for today's presentation. We hope that you have gained a new insight into shared decision making within neuro-oncology. And we'd like to announce the next eEANO webinar on disparity in clinical trials in November. And on behalf of the eEANO and the presenters, thank you for joining us today, and have a great rest of your day. Thank you.